Okay, so we are back to talk about fertility and the care of a patient experiencing infertility. So, infertility is defined as lack of pregnancy after 12 months of well timed intercourse. So, that's sort of a piece. Sometimes people don't know when ovulation occurs. It's defined as 6 months if the woman is over 35 years old because the chances decrease substantially at that age. Some couples may need information about timing intercourse. So, ovulation occurs 14 days prior to the onset of the next menstrual period, not smack in the middle of the cycle, not on day 14 for every single person, but 14 days prior to the next menstrual period. So, if you typically have a 35-day cycle, that ovulation will occur on day 21 on average. It's a good time to talk about those signs of ovulation. Stretchy, thinner cervical mucus. People can be trained to take their temperature or instructed to take their temperature before they rise to see if their see if their temperature goes up with ovulation. And there are ovulation predictor kits that people can get so that they can time intercourse. And those kits are really easy. They're just like pregnancy tests. It's a little stick that you put in the stream of your urine, and it will tell you when you're likely to ovulate within the next 48 hours. Infertility don't look at it as a woman's problem. It is a couple's problem, or it is a family problem. In the case of single mothers, it may be a woman's problem. But it's related to male factors about 35% of the time, female factors 35% of the time, combined factors 20%, and 10% we don't know. There's no identified cause. Overweight can cause infertility issues because of an imbalance of estrogen in the body. Underweight women, especially women with eating disorders, will stop ovulating, so they may be counseled to lose or gain weight to induce ovulation. An evaluation for fertility, when people come in and they say we've been trying to get pregnant for a year and we haven't had any success, we start with least invasive to most invasive. And that this is where you really want to stress. This is not only the woman coming in for evaluation. The male evaluation is not invasive. It just mostly consists of a sperm sample. If half of infertility is due to some male factor, or male factor contributes in half the cases, it makes sense to do the male evaluation with the less invasive female. Female evaluation usually starts with a good history, urine and blood testing, and then moves to things that are more invasive. Hysterosalpingogram is when they inject dye into the uterus and they sort of see where that dye goes. Does it get all the way through the fallopian tube? In some cases, that procedure actually opens up scar tissue in the fallopian tube. And the tubes become patent and pregnancy can be achieved. We look at follicle stimulating hormone. We look at estrogen levels on the third day. You can look at thyroid levels. Sometimes they look at androgen levels, but this box comes out of your book. You can look it up there if you want to. And for men, they're really looking at sperm motility and volume and number. And they're looking for the maturity of the sperm. So it really is a less invasive evaluation for men. Should be done as part of the initial intake. Clomid is a medication that we give to induce ovulation. It's usually the first line. That I have a doc who calls it a gateway drug. Everybody starts with Clomid. They don't think it's that bad. And then they move on to the injectables, and then they move on to the more invasive ART or assisted reproductive technologies. But Clomid is where we start. Usually start about 5 days after the start of the period. These are folks that are going to be in the doctor's office a lot. There is a risk of multiple gestation. That's probably your biggest risk. It's increased 7%, but they go up on the dose every month. If you start, say, in October, you're not pregnant. November, they're going to increase your dose a little bit. The risk increases as you go on. So if Clomid doesn't work, we have artificial reproductive technologies. There are injectable hormones that induce ovulation. These have higher risks of multiple gestation. There is intrauterine insemination. So you take sperm, either it's donor sperm or it's the partner sperm. It is spun around in a machine. They call it washing, so that only the best, strongest sperm survive and there's less fluid, and it's introduced into the upper uterine cavity with like a syringe that has a little catheter attached to it. It goes through the cervix, and they inject it directly into the uterus. So you're kind of bypassing some of the things that might be hostile to that sperm. And that's where some people will start. If that's unsuccessful, you can move on to in vitro. In vitro was successful first in 1984, and it's used, sort of as the be all end all. So what happens, you stimulate the ovaries with those injectable medications and you retrieve multiple eggs. You're trying to induce hyperstimulation almost of the ovaries. There's an ultrasound, they aspirate those follicles, then they mix them with the sperm so the eggs are fertilized in a dish outside the human body. Once they find embryos that look healthy, they can implant them into the uterus. If you are not ready, then they freeze them. So usually the woman in this couple has to go to the doctor daily to see if she is ready for implantation, or if she's ready for harvesting of the eggs first, and then she'll go back for implantation. And that's IVF. So those are some of the things that we can use to assist patients with fertility. Mostly it's emotional support is the nurse's role, education and support. The fertility journey is very difficult and stressful for most people. It can impact their self-image, and it impacts their relationship. It impacts their financial status if insurance is not covering it. Some insurances do, some don't. So mostly your role in this process is to educate and support.